As we gather here today, we are at a crossroads where the need for a patient-centric, sustainable, and trustworthy healthcare system has never been more pressing. The recent challenges faced by the Indian healthcare system have eroded trust, and it's time for us to come together to rebuild and restore the faith of our citizens in the healthcare system. This session is a call to action, a clarion call to co-create a healthcare ecosystem that prioritizes the needs of patients, promotes sustainability, and fosters trust. Over the next 75 minutes, we will engage in a thought-provoking discussion with our distinguished speakers who will share their expertise, experiences, and insights on how to rebuild trust and restore health in the Indian healthcare ecosystem. For the same, I would like to invite Dr. Hara Prasad Mishra on the stage as the session moderator. Dr. Hara Prasad Mishra is a physician and computational medicine researcher at the University of Delhi, India. He has worked on various projects involving AI and ML in healthcare with the Government of India, MNCs, and health tech startups over the last 5 years in various capacities. Please put your hands together for Dr. Hara. Next, I invite Professor Dr. Sanjiv Kumar. Dr. Sanjiv is the chairperson of 3 Domain Leadership Foundation India. He has 47 years of experience across more than 30 countries. He has trained more than 1,000 professionals in India and other countries. Please put your hands together. I'm quite sure we had a good break. We had a tea break. We are re-energized. Please show that energy via clapping. That's all I request. I would like to welcome Ms. Ankita Agarwal. Ms. Ankita Agarwal is a seasoned business strategist and has worked across various industries from private equity, healthcare consultancy, medtech, handling multi-million-dollar deals while working with Evercare, GE, Dell Services. At present, she is the Vice President, Marengo Asia Strategy Office, playing a pivotal role in shaping the company's vision. Please put your hands together. I request Dr. Chandrakant Laharia on the stage. Dr. Chandrakant Laharia is India's leading medical doctor with focus on preventive medicine. He is an international recognized health expert and worked with WHO, UNICEF, World Bank, and many other international agencies. Next, I invite Dr. Rishabh Jain on the stage. Dr. Rishabh is a consultant interventional radiologist at Fortis Escorts, New Delhi. He specializes in interventional radiology, digital imaging, MRI, fluoroscopy, and digital mammography. And at last, I would like to welcome Dr. Adil Khan Yusufzai. He is the founder of Stealth Startup with a mission to build India's first comprehensive patient-centered healthcare super app to enhance care access, improve outcomes, and simplify patients.
So, hello everyone. Am I audible? Okay. Fine. I think. Hello. Yeah. So we have a great panel to start with the topic. So rebuilding trust and restoring health. Can anybody mention any major incident that has happened in recent 1 week that talks about a lot of things?
Some guy stabbed.
Yeah. So a Chennai doctor, a famous oncologist, very senior person, has been stabbed. Day before yesterday in Greater Noida, a 7-year-old child was operated on the wrong side of the eye. And today morning when I woke up, I was not prepared to listen about this, that 10 newborns have died in a Jhansi hospital due to hospital fire. So this brings to the today's topic, that is rebuilding trust and restoring our healthcare ecosystem. Because if you try to analyze these 3 news that I have mentioned, on one side, the government or the infrastructure is responsible for the newborn babies dying in the hospital for a hospital fire, whereas there are rising cases of hospital violence against healthcare providers. And on the top of that, there are a lot of medical negligence cases, right? You can't have any kind of justification for operating on a wrong side of the eye, right? So to start the discussion, I will invite Professor Dr. Sanjiv Kumar to have a brief presentation. So the mode of our proceeding for the panel discussion is that some of the panelists will have a small 5-minute presentation, and once that is done, we'll have a focused panel discussion based upon their experiences and the current work they all are doing. So please welcome Professor Dr. Sanjiv Kumar.
In my next 4-5 minutes, I am going to give you 3 messages. The first one is trust building is a win-win situation for everybody. Second message is in health setup, we need what is called distributed leadership. So everybody is a leader, right from the security guard till the specialist whom the patient consults. And the third one is prevention. Let's not forget prevention, because India is becoming capital of so many diseases, and the disease burden is multiplying by the day. Coming to the 3 questions which I have already repeated, this is what will happen if you have trust built between the healthcare provider. I am not calling doctors, healthcare provider, because security guard is also a healthcare provider. Healthcare is a team, not just a doctor. So what will happen? Health outcome. This is 2.6 times better, not percent, 2.6 times better. Then you have organizational reputation, 3 times better. And then next 2 are in percentages. Patient loyalty, which is very important for compliance and continuation. And then obviously most of the hospitals today we have are corporate hospitals, and they are looking at return on investment. People have invested hundreds and crores of rupees, so they are not doing charity. So that also will benefit. Who builds trust? I have healthcare providers. What do? Every person in the healthcare team has to be patient with the patient. We become impatient. That is first thing we have to make sure we do. Communication has to be open, clear, and respectful. Respectful to the socio-cultural practices of the patient who is coming to you. I remember I was in a PHC, and I used to tell pregnant mothers, vegetarian, predominantly vegetarian, कि दाल दिया करो और पपीता दिया करो. सर ये तो गर्म होते हैं, बच्चा गिर जाएगा. अरे मैं डॉक्टर हूँ, तुम्हें मैं बता रहा हूँ. And the result was वो एंटीनेटल केयर में उनको आयरन फोलेट की गोलियां देते थे. मेरे मुंह पे तो नहीं मारते थे, पर PHC के दरवाजे पे फेंक जाते थे. मेरा एक रेड चेक चरक साइन था. फिर मैंने कहा उनको दाल में नमक डालो. हाँ साहब, दाल की तासीर गर्म होती है, नमक की ठंडी होती है. पपीते में थोड़ा सा नमक डाल लो. You need to understand and respect their socio-cultural practices. You will build a good relationship with them. Empathy and listening skill. Listening skill, 10% of what you hear is words. 20% is what you say, how you say, volume and pitch. 70% is body language. If you don't look at the patient carefully, you will not be able to understand what the patient is telling you. Honesty and honesty and transparency, non-judgmental. Availability 24/7. Very often you come across patient who was treated in daycare for medical treatment of cancer, goes home, and around 6 o'clock in the evening, nausea and vomiting starts. The patient doesn't know whom to contact. He has the manager's phone number, call the manager, manager says, I'll get back to you. The manager is not able to get to the doctor. Simple things, ORS. No, they should be advised to the patient, take 6 of ORS if you are vomiting. These things are missing. Patient-centric care involves the patient and caregiver in all the decisions you take for the patient. Adapt to change. Things are changing very fast, and we have been looking at that for the last 1.5 days. We need to be updated on that. Hospital management has a role. Hospital practices have to be patient-friendly. Most of the practices we have are doctors and healthcare provider-friendly. Visiting time, who will go where, how many people are allowed to accompany the patient, but not patient-friendly. Dealing with attendants and visitors. Courteous, respect them what they have. You have restrictions, yes, how many people can visit, but that should be handled in a very sensitive manner. Minimize hospital-acquired conditions, becoming more and more common and more serious. Easy to navigate in the hospital. Patient gets frustrated. He is told to go somewhere and he is asking 10 people, how do I get there? So maybe you can have lines on the floor, colored lines on the wall, and the patient can get to where they want to. And this frustration will be reflected in the behavior with the healthcare provider. Staff welfare. The staff who does not have trust in the hospital and management will not be able to build trust with the patient. So make sure that your staff is looked after well. Grievance redressal mechanism for the patient. If they have a grievance, it should be handled properly. Mechanism for feedback. From every patient can give you a feedback what was good and what needs to be improved, and provide technology solutions. Then there is the role of the government. Whenever something happens, like 2 instances you get, make a new law. The problem is not in the law. Problem is in the implementation of the law. If a doctor is assaulted, healthcare worker is assaulted, the police should run immediately as an emergency and take care that the violence doesn't get exaggerated. But I have not put those here. The government also has a very important role to play. This is distributed leadership. In healthcare team, you have distributed leadership. Everyone in the team is important. You have shared leadership, you have collaborative decision making, you have collective action. And then, most important person in the trust building is the person who comes in contact with the patient. Leadership at this level deals with day-to-day reality. Autonomy for routine decisions. You should decentralize routine decisions to these people and actively engage frontline health care providers in decision making on issues which affect them. It is rarely done. Shift from disease to health. And if you look at the whole population, you have people who are healthy. They neither have disease nor any risk factor. Make sure that you keep them healthy. Then you have next group is the population with risk factors. They are more likely to develop certain diseases for which they have risk factors. Make sure they are looked after more intensively than the first group. The third group is population with disease but they are not aware. How can they take care of their health if they are not aware? And the third one is population with disease. For example, in recent NFHS survey, giving you broadly the figures, half of the people who had hypertension were not aware. Half of the people who were aware, only their blood pressure. So it's only 25% of the patients you are able to treat effectively. And if you don't do that, health system will get overwhelmed. Then you keep hearing one capital of diabetes, cancer, cardiovascular, malnourished children. What about prevention? You have disease burden which is increasing by the day, and health system is overburdened, and what happens? This is what happens. You have this disease burden and you have healthcare providers. They get overwhelmed. They cannot. You saw in the second wave of COVID how the health system got overwhelmed. Thank you.
So, I'd like to invite Dr. Rishabh. So, Dr. Rishabh is an intervention radiologist. So, Dr. Rishabh will be sharing across his opinions about in and around diagnostics. So, Dr. Rishabh will be focusing on in an era of digital imaging, where the concept of digital imaging is improving day by day. Patient often nowadays feels left out, that I'm not a part of decision making. So, he'll be focusing on that, and let's hear his opinion.
Hi, good evening. Good morning. Good afternoon. Thank you, sir, Sanjiv, sir, for that broad introduction. And my talk today will not be anything regarding leadership in healthcare, because I'm not currently in that position. Maybe someday, yes. What I want to talk about mainly is what the work I do and how tech, AI, and future prospects in digital imaging is, and how, as a radiologist, we play a very vital role in patient management, patient diagnosis, and we should also play a very important role in patient counseling as well. Right? So just a brief introduction about me. I'm Dr. Rishabh Jain. I'm a consultant interventional radiologist at Fortis Escort Heart Institute, Okla, so sitting nearby. And this is me in that DSA angio suite. So I work in a cath lab. I'm an interventional radiologist. And some of you might be wondering what an interventional radiologist is. We've heard only of a radiologist. So we call ourselves plumbers of the human body. Right? So any vessel in the body which gets occluded, we open it up. So you have a stroke, you get a clot in the brain, you want to remove that clot, we go ahead, put in a fine wire through the vessels in the brain, take out the clot for you. You have a bleeding vessel in the abdomen, you underwent a trauma, had an accident, a vessel is bleeding, we close that vessel up. So we are plumbers of the human body, and through minimally invasive, high-tech driven hardware, we perform very high-end procedures on patients, right? So these procedures are done without GA, they are painless, they are done in a 3 hour, 2 to 3 hours, sometimes within less than an hour also, and very high rewarding as well. So it is a relatively new branch of radiology, mainly picked up in India in the last 20-30 years. And so this is what I do, and this is where I do it Fortis Escort. So this is an inside of my cath lab. You can see it angio suite and the patient's trolley and the associated hardware around it. So this is a broad overview of the hardware that I deal with. This is a biodegradable stent, which is the latest technology in interventional radiology. So just few more slides, I won't bore you much. So this is sort of a stent which degrades on its own after 6 months of putting in. So you don't have to take it out, it won't cause any foreign body reaction in your body. It is made up of a material which dissolves on its own. So there's a narrowing, you put in a stent, open it up, it gets dissolved in 6 months. Right? So very advanced tech, very advanced technology we are dealing with. Again, more sort of hardware. You can see there are basically catheters, wires, and tubes. Right? So a simple case I want to show you. So this is a patient who had a liver cirrhosis, underwent a liver transplant, and unfortunately after transplant developed jaundice, and he had an obstruction in the bile duct. So again we put in a balloon, open it up, put in a stent, and the patient jaundice got relief. So this is a broad overview of what I do and how tech has really helped us in improving the services that we provide. Now coming to the today's topic of rebuilding trust in healthcare. I think as a radiologist, primarily we have a very important role in patient counseling and patient education, because sometimes we are the ones who tells patient what the disease is. We are dealing with ultrasounds, X-rays, CT scans, MRI, and we are the ones sometimes who pick up a disease in the first place. Then the patient goes to the clinician. So I think as an upcoming thing, whatever the way forward for all radiologists in India is, number one, patient education. Talk to the patient. Whenever a patient comes for a CT scan, mostly the radiographer does the CT scan and the patient goes away. Ideally, radiologists should do a pre-procedure counseling, tell him or her what the test is about, what are the expectations of the test, and after the test is done, maybe ask him to sit along with you and show the scan, show what the findings are. Tell them in a patient-based language, whatever the patient understands, what disease do you have. So number one is patient education. Now, second important role of AI in general is, we also have a role to reduce the number of unnecessary tests. So what artificial intelligence is now doing in radiology is triaging patients who A, need an urgent scan, and B, if they need a scan, what kind of a scan do they need, and whether do they need a scan or not. So by analyzing a lot of clinical data, AI is good at analyzing a lot of data. So it can build an algorithm which suggests that yes, based on your symptoms, you are likely to have this disease, so you should undergo a scan, or this is a self-limiting disease, you can wait it out a little bit and then maybe follow it up with a clinician after 4 months and then we can repeat an imaging. So these are the two important things that I think the way future is: patient education, informatics, annotated reports. I do a lot of ultrasounds of lower limb in patients who have atherosclerosis or diabetes, right? And they usually have blocked arteries. Now, for the patient to understand such reports, what I do is that I draw the arteries by hand alongside the report and mention in the report where the blockage is. So, the patient is also educated. He gets that trust that yes, this is the problem that I have. It's very easy to visualize a disease than to bear it out. So I think that is one very important thing that all doctors, even radiologists, should do in their clinical practice. I think that's all. Hara, thank you so much for having me on this.
For mentioning about how the era of diagnostic is changing and how, because the first point the patient comes to know about the condition is from a diagnostic point of view, be it a pathologist, be it a radiologist. So thanks for mentioning that how we can improve, especially on the communication part by drawing diagrams and a lot of stuff to be stated. I'd like to invite Dr. Adil. So Dr. Adil is currently building India's first super app. So, and he's trying to build something which is outcome driven. So let's try to hear him out. What are his thoughts and how he's trying to bridge a lot of gaps and plugins.
Hello, yeah. Good morning everyone. And why did I say good morning? Because a pre-lunch session is the worst session. I remember myself sitting in one of these lecture theatres and I used to hate these lectures which used to happen before the lunch. I can see some people already drooling. I know you are imagining Shahi Paneer and Kadai Paneer. But okay, I'll keep it quick and sharp. So, since we're talking about trust, so there's a saying by Roosevelt that says medicine is a science of uncertainty, but it is the trust which turns uncertainty into a hope. And that's what doctors do. Patients don't go there for medicines, but they go there for a hope, for a trust to give them that they can be treated, they can get better. I'm sure आप लोग बीमार हुए होंगे, आप डॉक्टर्स के पास जाते हैं. And the moment you step out of the clinic, you're already feeling fine. It's because you trust that doctor that अब मैं better होने वाला हूँ. That's called placebo effect. Telling you a little bit about myself, I am a registered medical practitioner, but I don't practice medicine anymore. So very early into my med school, I realized that the kind of impact which I wanted to make was something which I can do by leveraging technology. So that's why I didn't go for MD or MS. I'm not a great physician, but I did my master's from Stanford to learn how to innovate and how to build solutions to solve real problems of healthcare. I've always been questioning status quo of healthcare. So I founded 2 companies before, and currently I'm building my second company. And I'll talk more about what I'm trying to do, but let me focus more on this topic because you can always know about me on LinkedIn. Yeah. So, I'm sure there was a great show back in 10 years back by Amir Khan called Satyamev Jayate. I'm sure, how many people have seen that show? Yeah. So I'm sure आप लोग हम पे ट्रस्ट नहीं करते होंगे. तो उसमें बहुत अच्छे से हमें हमारी बुराई की गई थी कि how healthcare system of India is crooked and how they are making money out of the people. And it's not true, but at the same time it's not false as well. And there's a reason behind it, because the care journey of a patient starts way before when they reach a hospital, and it goes on even after they leave a hospital. But hospital की जो concern है, hospital का जो incentive है, it is only till the patient is in the hospital, and because of that, patient is often left alone in a long care journey. Along with that, the systems of healthcare, like the doctor speaks in a language which are usually very jargon heavy, and it's a non-inclusive. Or for example, if a Kannadiga guy comes to a hospital in Delhi, he won't understand any word of it because people don't know that language. So the language barrier is there. On top of it, because of that language barrier, there's a big gap of health literacy, a knowledge gap. Patient expect something and they get something different. For example, my grandmom went for a knee replacement surgery. She thought she would come back like a Ferrari, but eventually she was a Maruti 800 because knee surgery के बाद आप एकदम perfect नहीं हो सकते हो. So this is the gap which I am talking about. But now I talk about how patient trust is important for business. Let me tell you, we are in a capitalist world. Everything revolves around money. End of the day, hospitals or anyone or patients, all they care about is money and the outcome. So we all know. So let me tell you about a little bit about hospitals. So these days, any hospital generate a patient by paying somewhere around 20 to 30% of the total bill to aggregators, referral doctors and stuff like that. That's a huge cost. But let me tell you a fun fact, even the patient who comes to the hospital and ends up having a surgery in that hospital is only 10%. 90% of the patients don't trust that hospital. That is really a big issue for the hospitals. And why they don't trust? There are multiple reasons. I will talk about it, how we are trying to solve. And as a result, now hospitals are starting to realize that they need to retain a patient for longer than what they are doing. They just need not focus on bringing in more patients. They need to give an experience, a world-class experience to the patient so that they end up coming again and again, or maybe do word of mouth referral. But the reality is different. In India, patient churn rate, I don't know, maybe it's a jargon for you. The churn rate means that almost 50% of the patients never go back to the same hospital. So why? Because they don't trust them. They always window shopping. They're like, मुझे ये पसंद नहीं है, मुझे दूसरे hospital में जाना है, मुझे तीसरा doctor के पास जाना है. So how can we bring back that trust? There are multiple ways. I can talk about what I can think of. Firstly, transparency. I feel patient trust or anyone's trust is based upon transparency. And we can enhance that transparency through basically educating the patient with the right words, with the trustworthy words, with the right emotions, with the right empathy. On top of it, building patient-centric system. When I say patient-centric system means they're putting patient in the center and surrounding him with him or her with all the services which are in healthcare. For example, I have been working with an organization called PAHO. Dr. Vijay was there yesterday. So we are building a multilingual patient education and consent system. We are ensuring that people from every strata and every region can understand those things. Then trust beyond hospital walls. As I told you in the starting, care journey doesn't start at hospital. It starts way before hospital, at home, and it goes on even after hospitalization. So we need to create a care continuum or ongoing care programs where patient can be finger-holded throughout the care journey and not just in the hospital. So now let me just tell you about what. So with all of these issues, me being a doctor, I always wanted to do something for my community so that I can actually regain that trust from the Indian population. That's my dream, to be very honest. And that's how I'm building this company. So this company is actually providing patients of a hospital and ongoing care before a hospitalization and even after hospitalization. And through this, We are actually trying to improve a clinical outcome and at the same time save money for the hospital patients. How our service is all cashless. Anything you need, it's all cashless. It's well curated for the patient, and we are providing a care continuum. Thank you, everyone, and I hope it makes more sense to you. And thank you.
Thank you, Dr. Adil, for taking the entrepreneurship route to solve the challenges in healthcare. This sets the tone for hospital administrative strategist and operational person. So we have with us Ankita from Marengo Asia Hospital. So Ankita, to start with, operationally and strategic standpoint, if I see, Adil has talked a lot about that Satyameva Jayate is there. I mentioned a couple of things. So it always puts the hospital in a back foot, right? So how do you see that what hospital should do and all are already doing to increase the transparency part? Yeah.
Thanks, Dr. Hara. Hi, everyone. So yes, I think Dr. Adil, Dr. Hara, Professor Sanjiv, I think everyone said about how healthcare is going, and I think I am on the other side of the panel where I would say that how we are doing healthcare in our hospitals, right? So I represent Marengo Asia Hospitals. We have 5 hospitals across India and growing. We have a private equity fund, and we are looking forward for a few more hospitals to come on board, and then we expand the chain of hospitals. So as Marengo Asia Healthcare, we started about 4 years back, where the strategy was we acquired good sized hospitals which have a good infrastructure, doing well quaternary care work. When we say quaternary care work, it includes all complex transplants, including your heart, liver transplant, renal transplants, lung transplants, and heart transplants. I think these are the most complex procedures which are happening today, and very few hospitals are doing. Okay, so we started the journey to acquire few hospitals. We have funds and are looking at acquiring few more hospitals across India, and we continue to grow this platform. Our mission or our motto is about 4 A's, where we say is accessibility, affordability, and then the 4th A which we added was the accountability, which was the most important A which we added, because we need to be accountable about the care what we are giving to our patients. So this is all about Marengo Asia Healthcare, and what we do in our hospitals for building trust, right? And what everything we kind of spoke about, and my dear panelists spoke about here, is that when a patient walks into the hospital, he is walking on his own. We are not, I'd say, if he thinks that okay, he can trust this brand, there are good doctors who provide ethical care, who are giving patient counseling, who are giving financial counseling. There are no exaggerated bills which are being given to the patients, and that's how the patients walk into the hospital. And that trust, I think, takes a huge amount of time for us to build, and that's how we have been doing it. Unfortunately, we see that there are a number of OPD footfalls which have been increasing across our hospitals. The IPD discharges are increasing about the hospitals, and people have a high brand recall value about the hospitals. So this all comes when not many teams are acting together, which is about right billing, right care, right patient listening, where the listening is the most important part, where the patients are walking into the hospitals, the doctors are listening them patiently, they are providing the right care, the outcomes are right, the financial counseling is right. We deliver what we commit, right? If we deliver that, okay, if we say that this kind of a procedure will be done in about 2 lakhs, it will be done in 2 lakhs, right? There will be no exaggerated bill, because after all, the patient is still worried about that how much of money he will be able to shell out. There are many hospitals or many healthcare providers, we say that, okay, we'll do this surgery in 1 lakh, just get in to the OTs, and when they are actually getting discharged, the bill is inflated to about 2 to 2.5 lakhs. Which we say that no, we held ourselves accountable, what we commit will deliver in that. And that's how we have single line packages in our hospitals, which is completely in and out. The patient is financially counseled, what all services he will be getting, why, so that he can make his decision that whether he has to get admitted into this hospital or not. And in addition to that, we are also taking care about the consumables what we give to the patients. So all our decisions are patient-centric. We decide that okay, the consumables or the drugs or the pharmacy, whatever are being given to the patient are of high quality, because so that we can take our family members also to our hospitals where we work. And that's how we kind of take care of a patient. There are a lot of deployed innovative technologies also to give a comprehensive care to the patients. So most of the departments are having zero code blue events in our departments. And the code blue, when we say, is about we have deployed technologies and sensors on the patients, right? Which is a small patch which is applied onto the patient even when he is into the ward or the rooms or the single rooms, which gives about all the vitals of the patient to a central station, and any preemptive alert, right? Whether this heart rate or the ECG will go up or down, can be pre-alerted to a nurse, and then he can be either shifted to ICU. And with that, when we were having about 6 to 8 code blue events in our department, which can get very critical for a patient, we have taken it to complete zero. So I think these are the innovative technologies which we actually deploy in our hospitals for building patient trust, patient care, and having good clinical outcomes. We also give a comprehensive care to our patient. For example, as Dr. Adil spoke about, the journey starts very much before the patient walks into the hospital, right? So we have all these kind of, I'd say, preemptive and the post-rehabilitation programs, where it's not only physical, but it's a hybrid model, where the patient can either walk into the hospital or can take the rehabilitation services sitting at home. Because we know that if any one of us, or even if I am being asked to come to hospital every day, right, or even every week, I may require a caretaker time who will take me to the hospital, right? Then I need to spend about 2 to 3 hours every day going here and there, and then even like, so I may drop out. That affects my outcome right after the procedure. But if I am able to provide the service in a hybrid mode, for example, in an online way, and whenever the patient is willing to come, right, the outcomes I am able to improve a lot. And I am able to continue, right, the patient stickiness, receiving of those care services which the patient is unable to avail today, because he thinks that okay, for everything I have to go to the hospital, and then every day. And so the whole day goes into the hospital because he has to travel, he has to spend time there, he has to come back. So I think these are all services I think we have been able to incorporate over the last 4 years and delivering through all our hospitals, where we have the zero code blue events, we have the pre and the post rehabilitation services running in an online and an offline way, the financial counseling about the bills not being exaggerated. So it's lot we are doing in our hospitals, and I think we continue to build trust the same way, kind of ahead also in all our upcoming hospitals.
Yeah, thanks Ankita for giving us critical insights from the point of a healthcare administrator. Now moving to the next panelist who will share a lot of different insight, I must say. We have with us Dr. Chandrakant Laharia, sir. So Dr. Chandrakant is primarily a physician and also running his own clinic called as Center for Health with Specialty Care. Apart from that, sir, I don't know how many of you are aware that there is a book called Till We Win. There is a book, and I hope a lot of you must have learnt about it and read it. So sir is one of the primary authors of that. So sir, can you please tell us that how primary health system can have more trust, especially for the society we are serving? Because you run a clinic, you have your own patient base. So how you are ensuring that with the word of mouth continues?
Thank you very much, Dr. Hara and the organizing team for inviting me. And you have asked a specific question, and before I go to a specific question, let me reflect about what I was thinking when I was coming from my place to this, some philosophical reflections. I was thinking that how many of you have ever, before this session, thought about trust in the healthcare? I was thinking that how many of you were thinking about restoring health? When I was in the car, I was thinking that will your life change once I finish this session? Like, you are here, why are you here? What will benefit you? So those are the thoughts which were coming to my mind. Will it be just another session of 75 minutes you are sitting here just because you got a certificate in the end, or a different purpose? And this is a serious thought that I was thinking that will it really change your life or change anything in your life after this session? And it was very difficult, like I was not able to think that what will it change. Like for example, I was really wondering that how many of you have thought what is people-centric health system or patient-centric health system or person-centric health system. We keep talking about all these words, but some of you might not before this session thought about it. Then I thought there are 4 Vedas, and one of the Vedas, Rig Veda, there is a verse, Ek Sat Vipra Bahuda Vadanti, which essentially means there is only one truth, and then intelligent or learned people keep interpreting in their own way. So the fact is that we keep hearing all of those things in a different way. We need better health, we need a trustworthy health system, and all of this thing, and sometimes it has limited value. For example, Dr. Hara, we are talking about patient-centric health system. There are 3 terms, and I'm not going to share my wisdom that okay, this means that, but this patient-centric health system itself is a term which was used 50 years ago. Since then, like Michael Bryant, a psychoanalyst in 1969 brought out the idea of patient-centric health system, that we should not simply treat the disease, but we should involve patient in the healthcare. But 20 years later, the patient-centric health system or person-centric health system, that especially in the context of HIV, they said, well, it's not enough that you think about patient alone or his current health condition. You think about his environment. And the most recent concept is a people-centric health system. And that was my reflection. That if I have to talk to you today, I have to think what you want to know. What is your interest? What you want to get out of this session, or just investing 75 minutes to listen to this thing. So what you will get out of this thing, I would say that if we are in a healthcare discussion and healthcare innovation discussion, the first thing is that, one of my messages, the first innovation in India's healthcare would be that when people start thinking about their own health, they start empowering about their health. Like there are young people, 20, 30 in this hall. They think that they are healthy and they don't need any health care, but they often, and this is through my experience with the people or patients, that often they do not think enough about their health. They do not invest in health. They do not know that what preventive health care they might need. The young people or the individuals do not know that what is the family history of a certain disease, diabetes, hypertension, cardiovascular diseases, which can affect them and which makes them more prone. So in my opinion, the innovation India's healthcare system needs, that empowering people about, and some of this was reflected by previous speakers also, empowering them about some basics and essentials of health. And I think that will start the people-centric healthcare system. Theory part is that they say that people-centric health system is one where people are involved in policy making, where people are involved in health system design, and where people are involved in health service delivery. So how this system will develop or build a trust? It will build trust when people know about their health care needs. So I run a small setup, and one of the components of this discussion is that talking about what you do. So what I am doing, I have left a particular job and then I started some of the innovations in primary healthcare. We focus upon empowering young people and every age group about basics and essentials of health. What additional we do? Some of the innovation, very minor one, but which will bring people to the healthcare system and which will build the trust of the people. For example, in my setup, every patient who comes to the clinical setup, we call it the doctor will call you, but essentially my staff calls that patient next day to ask how are you doing on the healthcare system. Because the weakness or challenge in India's healthcare system or any healthcare system is that once a patient visits a doctor or healthcare provider, they have at that point single access to the provider. But after that, there is no way that they can reach a doctor unless they book another appointment. But in our setup, a doctor will call you is a concept in which healthcare facility, our setup, calls the patient, asks, we want to ask something of patient. We in our setup also do what we call sliding scale consultation fee model. In this sliding scale consultation fee model, it's a consultation fee, there is a fixed amount of fee which is XYZ amount for a majority of the patients. But there is another amount of fee, they have a formal sector employment, but we ask, okay, your fee this much, but if you think this is high, you can go one level down in that sliding scale consultation fee. So we make it affordable, but of course it's the private sector, setups is not free for anyone, but definitely it is affordable, like they can opt for a lower level of fee. So these are the smaller models, innovations which we are trying to do. Coming to the concluding point that how to rebuild trust and how to restore health. I think ek sat vipra bahuda vadant, everyone has their own ideas and reflected about it. But I'm a strong believer that India's healthcare system will change when people empower them with the essential knowledge. You have to start with yourself, that have a self-assessment of your health. No matter which age you are, get some essential checkups done, get a family history, so you are empowered that what risk you have of certain health condition. Are you healthy in the real sense or you need someone's advice? If someone will tell you that you are unhealthy, you really do not know, but you need to have your own self-assessment, and that's the innovation India needs, and that will be beginning of the trust. Thank you very much.
Thanks, Dr. Ramesh, for your experiences and your viewpoints. So, audience, I hope you understand that India is a developing nation and most of the patients that are currently undergoing any kind of treatment in India are visiting any kind of government setup. I'm not talking about Tier 1 hospital like AIIMS or Darjat, I'm talking about PHCs, CHCs. So, Professor Dr. Sanjiv, you have been a policy maker and in leadership roles. How you believe that we can restore the required trust in the community health setup, especially in the government healthcare part? Quick question.
I was reflecting on this topic and I went back to look at how did we lose trust. You know, in 60s and 70s, and as a child I was growing up, I remember two of our family doctors. I was a child, maybe 6 or 7 years old. If I go to the doctor and tell my mother is sick and she cannot come, she will rush immediately. Give you another example, the second physician who was looking after my family, he came to know that I got admission in AIIMS Delhi. We came home. In a small town, it was in the newspaper, so and so got admission. He came home and told my father, if you need money, I will pay his fee. You know, this was the relation. That relation has got this. General practitioner has disappeared. You have many specialists. I'll give you two examples. One patient who had the stent implanted and was put on cholesterol lowering drugs. And he used to get severe pain, and we thought trigeminal neuralgia, we thought of it, and we were looking for a neurosurgeon who can operate and his pain can disappear. Till we went to a neurologist, and he said, no, your problem is the cholesterol lowering drug, because the sheath, like you have insulation on the wire, you have insulation on the nerve. That is rich in fat. So when you give fat lowering drug, that disappears and it was touching the bone. He reduced that dose and he became alright. So you're looking at humans in compartments. Nobody is looking at wholly, and that is one of the reasons why the trust is disappearing.
So
as a healthcare provider, okay, and as a common man, as a common people when we are sitting here, I think that accreditation plays a very major role in deciding and in building trust. If my hospital is accredited, right, or in fact any community center is accredited, what accreditation holds is a trust. For example, there will be a certain processes run in this fashion which are globally approved or which are run nationally, okay? There will be a designated manpower doing their precise roles so that no one is overlapping. You have 5 people, they are supposed to do this role, they are supposed to follow that protocols, stage 1, stage 2, stage 3, this is defined and that's how the department run. And then the modeling part comes. Once you have accredited the department, train the people, set those processes, protocols, then you get into the monitoring part, right? Whether the department which you accredited is working as per those protocols, whether the manpower is there, whether all the diagnostic tests are done, monitored, documented, right? That is important. So first, the accreditation visitor, because it's a common man, right? I will see how do I define terms, to which hospital should I go, right? And the doctor is of in relation to me, or I say that no, this department is accredited right by a national body and I can walk in because I know that I will get the right care there. So there are various accreditations, right? It's a department accreditation, then the hospital level accreditation as NABA, JCI. We are also working with FICCI, right? Where we are getting into the community centers and accrediting them, right? Where the Karakal is one of the accreditation, which because these are the centers which need accreditation. Most of the workforce is going to these centers and they don't know whether they are getting the right care or not. So when we accredit that Mohalla clinics, right, or the primary healthcare centers, that they have to function at a standard level, right, which is government approved. That's how the trust when it comes into the healthcare delivery system. So if I accredited about 5 private healthcare centers through FICCI, which I am working on, right, we have the required manpower, the trained manpower, the diagnostic tools, the equipments, right, the data being documented, how many patients walk in, the diagnosis, what were the outcomes, what were the medicines given, and that's how the monitoring continues over years. And then the accreditation is renewed, right, every year. That's how you build sustainability into your ecosystem.
Yeah, thanks for that. So this brings to my new arena. Consent plays a very important role in healthcare, right? So, Adil, you're working currently on some consult digital platforms in collaboration with Kaho. So, can you focus on that part, like how the consent platform can help? Because it is in multiple languages, if I'm not wrong.
Yeah, thank you for asking me this question. I feel before anyone goes through a surgery or a big procedure, there is a requirement of a very transparent education in a way that is easy to understand by the patient in his or her own words, in his or own language, and things which he can start to believe. For example, I'll tell you, I was having a discussion with one of our doctor before this session. He said कि patient को हम बोलते कि आपको ये दवा की जरूरत है या आपको सर्जरी की जरूरत है, वो तब तक नहीं लेगा जब तक उसको नहीं लगेगा कि मुझे जरूरत है इसकी. और वो इंश्योर करने के लिए there is a requirement of a very thorough and a very easy and absorbable education material and a way to communicate those things. But doctor के पास time नहीं है. We are in a population of 1 billion, more than 1 billion. So doctors have a limited time. So there has to be a product or a technology where patient can actually ask those questions with FAQs and things like that. So that's how we are doing it with Kaho. So Kaho is an organization. They are a sponsor here. I saw that. So they build solutions. They don't build, actually empower healthcare organizations to maintain quality, as Ankita said about accreditation. So they are trying to build a free solution. So this is a non-profit product which I am building because I care more about outcome more than money. So I building this for free for any one of the people who are going for any procedure. They can just go to their website, click on their procedures, and then they can see in every education material which is available in their own languages. And along with that, it's all vetted with proper referencing, so that you don't have to go and Google things and end up Google telling you that you have a cancer. So yeah. Thank you.
I think Professor Dr. Sanjiv, some quick comments.
I wanted to share 2 things with you. I am amazed. Why do you have to call patient-centric? Can you have healthcare without patients? This is ridiculous. We have moved away from the patient and now we are trying to bring the patient back in. The second point I want to make is, in 2017 health policy, we had included health as a human right. Because this is included in right to life in our constitution, and Supreme Court interpreted that right to life includes right to healthcare and necessary things which are required for health. So if not today, but the politicians will say, no, let's not do it now. We are moving towards right. But it is going to come. In a few years' time, we'll pull up our socks because you will be able, it is judiciable if it is right. They will take you to the court of law. Any patient can take you to the court.
So this brings to the next part, that is diagnostic part, right? For example, once you have in the hospital, you have done with your consent, you have given the rights, so you mostly get into a procedure part, right? So Rishabh, a quick question on that part, like in general, for example, a couple of days back, one of my friends called that, Hara, I got some tests done, it costed me around 15,000, but there was no finding. So I told that you should be happy about it, right? There is no finding. So primarily healthcare is like that, like you invest money, but it's not a movie ticket, right? So Rishabh, how you are ensuring that unnecessary tests are not there, and how you convince the patients that this test is required, and a lot often they might question you. That is quite costly also.
Yeah, so mostly we have to rely on data for that. So the best way to alleviate a patient's anxiety regarding an essential test is to show him or her the data. That okay, you have this symptom, according to the present literature, this symptom can lead to this disease, and hence you need an investigation to prove that disease. So most of the times we rely on data, and then comes other soft skills in the process, how you talk to the patient, how much time you spend with him or her. A lot of my very senior professors, HOD of the departments, talk them very friendly, talk about their family, talk about build a personal relation with them, and that also builds our trust. So eventually the patient has to trust you that okay, whatever you are saying is beneficial to them. Number one, for that can be data, and second point can be a personal relation with that patient.
Yeah, absolutely. Dr. Chandrakant, what do you feel like how we can scale up the primary healthcare, especially in terms of technology? Because just like a lot of panelists mentioned, you don't have primary physicians existing anymore, and it's like a hard truth. The family physician concept is slowly moving out, but ideally it should be there. So how innovation can help there?
I think there is a clear binary in India that people think that okay, primary healthcare services mainly are for government, and then secondary or hospitalization services to the private sector. And now that's a major challenge. The thing is that the majority of doctors are in the private sector, or in the government there is only 10% of the total medical doctor or nurses or other staff healthcare providers are there. And they cannot provide all the services, they provide only small proportional services. So if we want to really expand the primary healthcare services, we have to find innovative approaches and models to engage private sector in delivering preventive, promotive and other type of primary healthcare services. So we need to bring models where we want to engage private sector, where it is profitable, but at the same time primary care is does not get enough attention because of the people also. The people do not go to healthcare provider.
Absolutely.
Until they are really unwell or their health condition has worsened, and when they go at the later stage of sickness, they might require hospitalization or other complex intervention. So when as a society or an individual we start adopting a lifestyle where we start seeking preventive and promotive interventions, we volunteer that we want to get a health checkup done, we identify as an individual, like a doctor or healthcare provider will follow what people want to do.
Absolutely.
And so if people start following and going to a general physician or other provider, the provider themselves will start delivering a broader range of preventive health services. So it's a societal perspective. And that's a reflection. And that's why I want to conclude my this second intervention also with the point that how and what will be the shape of India's healthcare system will be determined by healthy people like you all and us all in this room. How we handle our health. If we start paying attention to our health, we get a regular health checkup done, we select a primary care physician. It will shape the India's healthcare system. It will make India's healthcare system primary care centric.
Just to add on to here, thanks for
Quick comment.
Yeah, very quick comment. So I think primary healthcare can be strengthened. Why when we have I think 3-4 major things when we are working there. One is obviously we have to strengthen the infrastructure, right? Which when we are working with on a model with FICCI as a kayatal accreditation, right? So once you improve the infrastructure, the private player can come where they can train the workforce there, right? So if you have a trained manpower, the trained doctor there sitting in a good infrastructure where we have the right diagnostic tools, right? Then he can actually provide the right care. And then the accreditation part where people believe as part of the primary health care that no, yes, this is the right center where they can go and have their right care. The fourth most important part which I say is the Ayushman Bharat scheme here, right? Which has made it accessible and affordable and accountable. So I think I am acting on all 3 A's here. When I say accessible, yes, there is a Mohalla clinic there which is accredited, which has the right set of doctors, right, and the person having a Ayushman Bharat scheme, right, where he is covered about 5 lakhs, he can go to that center, right. So is the accessibility I have created. The accountability part comes, when I have accredited center and holding that center accountable for giving the right care, okay. So I am connecting these all 3 A's when I am setting up that center, training the workforce, accrediting it, and empowering people to go to that clinic and have the right care under the Ayushman Bharat scheme.
Yeah, absolutely. So, Rishabh, quick comment.
So this was a question to actually Ankita. So I wanted to ask because I belong to a type 3 city. So a lot of doctors in my city have around 10 bedded hospitals, 15 bedded hospitals. They are run by a doctor couple. They have good footfall. They are doing well. And as a corporate chain, as a corporate healthcare professional, is there any model that the corporate healthcare looks at in which it works on a franchisee model for those couples, or small establishment hospitals? Because what happens to them eventually is, number one, they work for around 20-30 years, maybe their next generation is not a doctor, so either they sell those things or they shut down, right? Second important thing is lack of trained staff. So trained staff availability is predominantly there in Tier 1, Tier 2 cities, lacking in Tier 3, Tier 4 cities. So if there is a franchising model sort of thing, because that happens a lot in teaching industry, is there those models which are A, feasible and B, being worked upon?
So thanks Dr. Rishabh. So yes, this kind of a need exists there in our ecosystem, right, where the centers are there and the expert doctors are not willing to go to Tier 3 or Tier 4 cities. That has been the truth and we have to accept it. The only model which can run here is a hub and spoke model, right, where we can assist them with certain training, the infrastructure and everything, right, and then there has to be an expert doctor connected there. Maybe he goes once monthly there, okay, teaches, thinks about the department layout, assists them, and then all the expertise can be provided via hub through a teleconsultation model. I think this is the thing which we have been doing throughout, and then we empower the center, actually the partner spoke hospital in whatever way they want. But expecting a senior doctor to go there in Tier 3, Tier 4 cities will not work, has not worked.
So let's say there's a city.
Actually, we can continue with the lunch discussion. So making some final comments, Professor Sanjiv, last quick comment in 30 seconds. You talked about implementation, right? There is a lot of healthcare violence happening, violence against healthcare workers, and that is very important because Ankita mentioned a lot about ecosystem. So peace of mind is super important, right? You can't function where you have your health risk also. So quick comment that how implementation can be better.
I'll start with primary health care. When you think of increasing agriculture production, who do you think of? The farmer. And he cultivates. But when it comes to health, primary health care says we provide services at the doorstep. But what happens in the family is producing health or disease. So we have to give more attention to what can be done in the family. I am hypertensive for 2007, now 17 years. I have gone to cardiologist once and to physician maybe 10 times. I am a doctor, so maybe that's why. But who takes medicine regularly? My wife reminds me, my children sitting in the US and Canada, they remind me. Papa, dawai le rahe ho na? Then I say, dawai le rahe. And coming to the question?
Implementation of laws for safety of healthcare workers.
Okay. There are laws, but I feel the implementation of law is not proper. You can enact any other law, like we have, Nirbhaya case and then the recent case, make another law. But the case was not launched, FIR was not launched, the girl was cremated hurriedly. What is happening to implementation? So we have to focus on implementation of law, and the hospitals have to be in close contact with the authorities like police and judiciary, so that things can be done fast. Because you give punishment immediately, it will be a lesson to everyone. It goes in the court for 5 years, 10 years, half of the witnesses disappear, and the person who has put the case in the way also loses interest, and then the chaos continues.
Yeah. So making concluding remarks, so it was great to have you all. We had a great discussion around how to encourage the trust building factor, and I hope the audience enjoyed. Any questions, anything, I hope we can have it in the lunch session, because one question, just one question, because others are waiting for the lunch, I guess.
At the outset, I congratulate innovation theorists to take the trust rebuilding. The trust was there, but it has to be rebuilt. I want to narrate my own experience when I walked to the doctor's clinic. The first thing they will ask, "Aapki doctor kya hai? Aapka insurance hai?" And I was admitted, and then I got the discharge summary. I'm from a nursing faculty, so I knew what I had done. And then I said, "ये medicine क्यों दिया sir?" I said, "ये आपको लेना नहीं है, आपको ये दवाई खानी नहीं है, ये तो इंश्योरेंस को जस्टिफाई करने के लिए मैं ये लिख रहा हूँ." Can you just imagine in this era of information technology and everything, where is the healthcare going to? This is, and it is not only there in India, it is throughout the world. I had many experiences in that. So somebody can work through innovation or insurance. What is that? Thank you.
I think Ankita can answer quickly then.
Okay, so ma'am, it's very unfortunate you had those experiences. Yes, I mean, see, there are certain outliers, right? When we are having so many doctors, there can be outliers. But as a doctor fraternity, I can only see that whenever any doctor or any hospital is taking any doctor, I think they have to check their proper credentials, right? Whether they have those relevant certificates, the experience is valid or not, because there are not many bogus certificates which are there in the market, and the doctors actually position themselves as a very senior doctor. And then the hospitals also kind of take those doctors that, okay, fine, the doctor is willing to come at such a such salary. I agree. So, as I said, it's very like, yeah, so no, I just wish to say that there can be outliers at a personal level. That brand, I would say, may not be held accountable. They should have done proper credentialing of the doctors, right? And they should have the right set of doctors. Otherwise, one or two, maybe I think there can be outliers where they are very personally driven, right, but not as an organization motto. Another thing which if you have handed over the mic to me is, see, at Marengo Asia, we also are working outside the hospital domain, what we have, okay? So we're actually working with IITs, where we are actually helping them innovate. Because the two associations need to collaborate. So we're also working on the brain signal capturing wheelchair with one of the IITs, okay? We are also working with the UK Research Institute on identifying cancer, how it can be pre-diagnosed, right? Where the tumor might arise, how big the tumor may grow over a period of time, and whether the right intervention has to be taken at what time. So as a healthcare provider, our responsibility or accountability also holds that we let's say, entertain or say allow the young innovators, right, or the young institutes like you to get onto the shop floor, understand what the problem is, and then drive innovations. Okay, innovations cannot be done sitting in a room. Please get onto the shop floors, reach out to me or Marengo Asia Hospitals on LinkedIn. If you really think that you want to innovate and explore new ideas, we'll be very happy to help.
Yeah, we have an innovator award ceremony also, so you can look out for good candidates.
Definitely.
Yeah.
I want to share one study, and you have raised a very right question. There was a study done in Odisha. They looked at the prescription of the doctors. Tell me a figure, what percentage of prescription was right? No unnecessary medicine, no unnecessary diagnostic. What percentage?
We have done a study,
2.2%. 1 out of 50.
We can have further discussion on the
Actually,
the audience is...
Irrigation help. I will say irrigation heal thyself.
Yeah, absolutely. Absolutely. We can have further discussion. We have 45 minutes for the lunch, and I will encourage all the participants to have a good interaction with all panelists. Thank you for your time. And
I'm quite sure everybody is waiting for the lunch. But again, this was a very informative session. Please be seated. I'll announce when the lunch would be. And from people to policies to patients to a lot of things we covered today. So please a huge round of applause for all the speakers. So I request Dr. Hara Prasad Mishra to please come forward and felicitate the speakers. Professor Dr. Sanjiv Kumar first. Please, a huge round of applause. I know we are lacking on the energy now. I know. We'll be refueling ourselves soon. Miss Ankita Agarwal. Dr. Chandrakant Laharia. Dr. Rishabh Jain. And Dr. Adil Khan Yusufzai. Please put your hands together for Dr. Adil. And I request Professor Sanjiv Kumar to please come forward and felicitate Dr. Hara Prasad Mishra. A huge round of applause, please. I request all the speakers to please come together for the group photograph, and then we will be proceeding for the lunch.